Morning, everyone. Can you guys hear me okay?
Yeah.
Okay. I
Yeah.
just wanted to make sure because I just plugged in all my stuff and I wasn't sure if I had sound or not. Okay. Um, so we only have 2 chapters to go through in class today, so it shouldn't be too bad. We'll go through those, and then I want to do some practice questions with you guys on this Davis Edge thing that I have access to that you guys don't. So we'll try that for a little bit, and then we'll be done with class. So I'll give people a couple more minutes to get in here, and then we'll start. Let me find our PowerPoints here. Okay. While we're waiting on other people to get in here, I just wanted to, kind of give you the update on what's happening in class in the next few days or next few weeks. So here's today, week 7. So we got chapter 10 and 14 we're going to go through today. So this is like the last of the OB stuff that we're talking about today. And then, officially week 8, that's when you start into all your PEDS stuff. So you guys are done with Mrs. Costello for clinical now, so that's good. So that part of your class is done, and then you'll start with Mrs. Vavrick, here pretty soon with your other PEDS clinical stuff. So what I wanted to say is next week, week 8. So normally, that's like a finals week for everyone else on campus who is just, doing the shortened programs and not the BSN. So we will still do our thing on Wednesday. I have to do some type of CPR thing that day. So Dean Newman said she's going to have someone proctor your test for me. So you guys will be here normal time on Wednesday morning to do your test with whoever it is. She didn't tell me who it is yet. So they'll be here at that time. You'll do your test, and then you don't have to stay online after that. You can get off. I will record anything that you would have had to have learned that day, and you can just watch it that way. That way you don't have to worry about, someone else telling you things. So I'll have everything recorded and posted, and you guys can just look at it that way. So that's week 8. And then week 9, we don't have class as well because it's, the first week of July, and we have the 4th and all that weekend. So we're just off from school that week. So again, because we don't have class and normally we would be missing all of this stuff, I'll record things. So all of that will be online for you guys to look at. So that's kind of my plan for that stuff. I did reach out to another friend of mine who is a person who has done PEDS in the past, like they've actually worked in PEDS, and she is going to be our guest speaker on the 8th of July. So she'll be on that day with us, and she'll tell you all about this stuff. So that's kind of the plan for the next few weeks here, just so you're aware. Okay, so let me find the PowerPoints here. All right, so this is chapter 10, the high-risk labor and birth stuff. And also, I sent you guys all an email this morning I was at a baseball game last night and I did not have cell service, so my email would not send from my phone last night. So I would have done it last night. I apologize. But I got a few emails from a couple of you guys about the OB proctored exam remediation. And so I agreed to let you guys turn it in by midnight tonight. So if you did not already get it done, you still have the rest of the day today to get it done. So I need to see one from every one of you by midnight tonight. So make sure you're working on it if you don't have it done. Okay, so let's get into this stuff. All right, so this chapter is just about high risk labor and birth stuff. So there's quite a bit in here actually. It talks about any kind of problems that you might encounter during labor and birth and interventions to help with those complications. So we as nurses have a key role in identifying complications and implementing nursing actions to achieve a safe birth and improve maternal and neonatal outcomes. Okay, so this is talking about dystocia, which I guess maybe I didn't realize what exactly this meant until I started reading all of this, but dystocia is the most common reason for a primary cesarean section. So what it means is it's a difficult labor, so a labor that is abnormally slow. So this person just doesn't seem to be progressing. They're taking forever to get from one stage to the next in labor. So the things that are related to this are the powers, the passenger, and the passage. So we're going to talk about each one of those things. So the powers, this means uterine contraction, like how effective are your contractions. And then also the expulsive effort, how much how much strength you have to like push the baby out. The passenger, this means it's fetal presentation. So how is the baby presenting? Are they breech? Are they head first? What are they? Also the position or the development. So if a baby is laying like side lying, they're not going to be able to get down the passage, right? So you're not going to progress because they're laying the wrong way. And then with development, if the baby is very premature, so if they're not developed enough, then maybe they're just not ready to come out. So all of that kind of plays a part. And then the passage. So this is the maternal bony pelvis or soft tissue. So sometimes the mother, just the way they're built, they can't accommodate getting this baby out. So maybe their pelvis is just shaped funny or something like that. You never know. I remember talking to my grandmother about this years ago. My grandmother is a really small, tiny woman, and she had a huge baby. My uncle was like 10, 11 pounds. He was huge. And I remember saying to her, how did you even do that? I don't understand how you got him out, because she didn't do a cesarean. She did it vaginally. So she must have had a decent pelvis where she could actually accommodate that. So anyway, so those are some of the factors that affect why someone might not be progressing like they should. And then this mentions risk factors. So there's certain things for that. So congenital uterine abnormalities. So if maybe your uterus has an issue, maybe that's why you're not progressing. Malpresentation of the fetus, just like we were just talking about. Maybe it's face presentation or something. Cephalopelvic disproportion. Tachysystole of the uterus with oxytocin. Maternal fatigue and dehydration. And, I will say this, especially if you're sitting there and you're pushing for a long period of time, because I actually did this with my daughter, my first baby. I pushed for like probably 3 hours straight, and it was just ridiculous. So I kind of had this, I guess, in a way. I wasn't progressing and I just was exhausted because that's, 3 hours of that. It's just difficult. So you do get very exhausted and you have this fatigue and you just don't feel like you have any strength to do it. So I get it. That definitely plays a part. Also, some other things that put you at risk would be administration of analgesia or anesthesia in early labor. Sometimes if they do it too early, sometimes you just don't have the feeling of when to push or how to push, because you just don't have that feeling at all. And then extreme maternal fear or exhaustion, which can result in catecholamine release interfering with uterine contractility. So I kind of picture, maybe like a very young mother, maybe like a teen mother or something where she's just scared, because she's so young herself. And she is causing this to happen because she's just, so scared and unsure of what's going on. So that's kind of how I picture that. All right, so then this gets into a little bit about uterine dystocia. So what this means is you have a lack of progressive cervical dilation, you have a lack of descent of the fetal head, or both. You could have weak or uncoordinated uterine contractions. In labor characterized as either hypertonic or hypotonic. So let's talk about that for a second. So hypertonic contractions. These are contractions that are frequent and painful, but ineffective in promoting dilation and effacement. So you're having them like pretty regularly, but they're just not making you dilate or do anything, which would be horrible. Nulliparous women are more subject to abnormal early labor. So what they do for this, like for management of hypertonic labor, contractions, they try to hydrate you more. So they say if you do hydration, it can help improve perfusion and coordination of the contractions. They also try to manage your pain pretty well, because if you're in a lot of pain, that could be, part of the issue there. So if you give them pain medicine, it allows them to sleep a little bit. It prevents exhaustion. So hopefully they can, actually do it. And then also promote relaxation. So sometimes like just, having someone in a warm bath or a shower or something like that might be helpful. Making a quiet environment. Allowing for long periods of time where they can sleep during this, especially the early portions of labor. So that's hypertonic contractions. Hypotonic means that you have pressure of the uterine contraction, but you have little or no cervical change with it. So these contractions that you're having are very insufficient, and you don't have any dilation or effacement that happens as a result. So instead of them being really regular, like with hypertonic, they're like, few and far between. So you might have one here, long period of time before you have another one, and then finally you have another one. But they just don't do enough to cause you to have what you need to have happen. So with this, the women's at risk for exhaustion and infection related to prolonged labor. The fetus is at risk for intolerance of labor and also asphyxia. So what they do with hypotonic contractions, if that's what's going on with the woman, you would try to augment labor by starting oxytocin. They could perform an amniotomy. And then they're going to watch this woman throughout this. And if the fetus starts to not tolerate labor, then you're going to go ahead and just do a cesarean. So that's kind of the outlook of hypertonic and hypotonic contractions. And that's, talking about uterine dystocia. Okay, so with active phase disorders, what this means is you have an arrest of labor in the active phase. So this means that the woman must be at least 6 centimeters dilated to be considered in the active phase of labor. The membranes have ruptured, and either they have been pushing for 4 hours or more with adequate contractions, or 6 hours or more with inadequate contractions and no cervical change. So if that's the case, you have to call it at some point, So you're in active labor, you're dilated big, but nothing's happening. You can't get the baby out. So you would probably go towards a C-section at that point. All right, the second stage disorders. Second stage arrest. This means that you don't have any progress or descent or rotation of the baby. Like the baby's not coming down, he's not rotating like he should. And this is for 4 hours or more in nulliparous women with an epidural, and 3 hours or more in a nulliparous woman without an epidural, and 2 hours or more in a multiparous woman without an epidural. So what they would do with this, so again, you're in that second stage, so you're already dilated and stuff, but the baby's not moving and doing what it needs to do. So what they would do is they might either assist with the birth with like the vacuum extraction or maybe forceps, or they may, go ahead and do a C-section if the baby's not tolerating things. So it just kind of depends on where you're at that point. All right, precipitous labor. Okay, this is kind of scary. I don't know if anyone knows anyone who has done this before, but wow. So what this means is it's labor lasting fewer than 3 hours from onset of labor to birth. So this means that, like, sometimes people, they'll start having contractions and it'll be hours, before they give birth. It's a long period of time. But with this particular person, it's a really short period of time. So the minute they start having contractions until the baby comes out is like 3 hours. It's crazy. So I forget who I was listening to. I was listening to some thing on TV, and someone was talking about their wife having a baby, and it was like that. They said they called 911 or something, or they were on their way to the hospital, and she ended up having the baby in the lobby of their hotel or their apartment building or something, because it just came so quick. They didn't have any time. So people who are at risk for this are people who have had multiple babies before, so multiparity, and then also just having a history of doing this before. So maybe your last baby was really quick, so now this one's going to be quick as well. So that's kind of the risk factors for it. All right, fetal dystocia. So this is something that can be caused by excessive fetal size, malpresentation, fetal anomalies. So what you do when something like this is happening, you're going to just confirm the position of the fetus, see where it's at with an ultrasound, and then either do like a vacuum extraction or a forceps extraction or a C-section. And then pelvic dystocia. So this relates to contraction of one or more of the following planes of the pelvis. So there's 3 contractions of the pelvic planes. So there's one called inlet contractions. So this occurs when the widest part of the pelvis is very small. The second one is mid-pelvis contraction. This is related to prominent ischial spines, convergent pelvic sidewalls, and narrow sacrosciatic notch. And the third one would be outlet contraction. So this can be measured by the transverse diameter of the pelvis. And what they would do is they would perform a vaginal exam to evaluate the progress of labor. Okay, so then this gets into induction. So when we talk about induction, this is when, the mother doesn't go into labor on her own. So it's like you are causing her to go into it by something that you're doing. So a lot of times, years ago, they would just like do this, no big issue. They would do this all the time. But now they're like, studies show that outcomes for newborns are greatly improved when gestation is longer than 39 weeks. So you wouldn't want to induce someone too quickly unless you absolutely had to, because you want to have a better outcome for the baby. So labor interventions are medically indicated when either the condition or safety of the woman or fetus would be improved by, them giving birth. So because spontaneous labor is associated with fewer complications than induced labor, induction without a medical indication is discouraged. So now they are a little bit more stringent about just inducing anyone. So some things that might be indicators for induction. So a post-term pregnancy. So meaning that you've had the baby in for a long period of time and now it's just time to come out. A premature rupture of membranes. So this means that maybe your water broke, but if a woman's water breaks, you have a certain period of time that you have to give birth. You have to have this baby come out, because if you don't, you're going to have a chance of infection and all kinds of things if you don't. So yes, this would be a reason for induction. Preeclampsia or eclampsia, that would be another reason. Remember we said that has to do with the high blood pressure, and sometimes it involves, people who have seizures and things too. Gestational hypertension is another one. Fetal demise. So if you can tell that the fetus is having problems, yeah, sure, you want to get it out as quickly as you can so you can help. Problems with the placenta, like abruptio placenta. So some of those things would be reasons why you would, induce. So there's a couple of different things that they can do to help get labor started. So one of the things would be to give oxytocin or Pitocin. So this is one of the most common induction agents used worldwide. And the uterine response to oxytocin occurs within 3 to 5 minutes. So it works pretty quickly. After IV administration begins with a half-life of 10 minutes. So it works very fast. So I want you guys to make sure you specifically look at oxytocin. So in your book, there's stuff on pages 311 to 314, all about oxytocin. So make sure you look at that specifically, because I know there's some questions about that on the test, and I want to make sure you have a good understanding of it. There's, like, you as a nurse, if you're giving someone this, you have to watch really closely what's going on with the patient and the baby during this. So if there is a problem, like, how when we were talking about fetal heart rate with Dr. Silva, weeks ago. So if there's an issue, you have to know what to do with that oxytocin. If you turn it up or down, or if you have to turn it off, there's a lot to know. So you need to make sure you look at that. There's also something called cervical ripening that you could do. So cervical ripening is just a process of physical softening, thinning, and dilating of the cervix in preparation for labor and birth. So the cervix will thin, soften, relax, and dilate in response to uterine contractions. and this allows the cervix to easily pass over the presenting fetal part during labor. So there are a few different ways that you can do cervical ripening. So they do have a mechanical way that you could do it. So in the book, it talks about two different ways. There's like some kind of hygroscopic dilator. So this is something that it absorbs water from the cervix and leads to expansion of the dilator and opening of the cervix. So it's like something you put in that will lead to all of this absorption of the water from the cervix, and it makes it expand and get bigger. There's also like a catheter type of a thing that you could put in. So just think of like what a Foley is like. It'd be similar. So they put this balloon catheter in there and, inflate that to help dilate things. So with either one of those two things, it's usually a physician or a midwife that would place them. So it's not going to be just a bedside nurse. And these things would stay in place for 6 to 12 hours before they remove them. Then there's also like medical or like pharmacological things that you could do to help ripen the cervix. So on page 317 in your book, there is a table 10-3 that shows that. There are, I want to say like maybe three different meds they use, but I wrote down two for sure. So Cervidil, so Cervidil, and then also misoprostol, which is very common. So both of those two things could be used for this. And then there's another thing that they could do as well that will kind of help get labor going. This is stripping the membranes. So what this is it's digital separation of the chorionic membrane from the wall of the cervix in the lower uterine segment during vaginal exam. So usually this is done by the primary care provider to stimulate labor. So those are a few different things that you could do to get labor going for induction. And then the thing is, when you decide that you're going to do this, when you decide that, induction is the thing you're going to do, you have to make sure that the mother knows all of the risks and that you are aware of all of that. So some of the things that can happen would be tachysystole. This is leading to a category 2 or 3 fetal heart rate pattern. Another risk would be failed induction of labor. Maybe even after you do all of these things, labor doesn't start to happen. So that would be bad. And then a third thing that would be a risk would be water intoxication. So this can occur in high concentrations with large quantities of hypotonic solutions, but usually only with prolonged administration. So if you have this up for a long period of time, sure, this could happen. But if you only have it up for a short period of time, it's probably not going to be a big deal. You're probably not going to see that. So during induction, things that a nurse would do. So she's going to do the external fetal heart monitoring. You should evaluate this every 15 minutes in active labor and every 5 minutes in the second stage. You are also going to be doing the vaginal exam. You're checking for cervical dilation and fetal descent. Usually, if you see a cervical change of about 1 centimeter an hour, that indicates you're having some good progress. During the infusion of oxytocin, the attending or another licensed provider should be available within 30 minutes to manage any kind of complications that could arise. And then also you have to make sure there's a physician that has privileges at the hospital to perform a C-section if that should be what needs to happen. So they need to be available at any given time. Okay, so then this gets into a little bit about augmentation. So this is stimulation of contractions when labor fails to progress. So indications for this would be to strengthen and regulate uterine contractions and to shorten the length of labor. So risks again would be tachysystole leading to a category 2 or 3 fetal heart rate. So during this, nursing care would be, administer low dose oxytocin, monitor the fetal heart rate and contractions, and turn down or discontinue the oxytocin in event of uterine tachysystole or a category 2 or 3 fetal heart rate. Okay, so the question is, which of the following is a method of induction? So it's going to be D, all of the above. So yes, you can use oxytocin or Pitocin. When it says sweeping the membranes, that's like means stripping the membrane, same thing. And then the cervical ripening. All three of those things can be stuff that you can do to get labor going. Now, I did want to just give you a couple of definitions just so you know what the heck I'm talking about with some of this stuff. Earlier on, I mentioned something called an amniotomy. So amniotomy, I'll spell it for you. It's AMNIOTOMY. What this is, it's artificial rupture of membranes to induce or augment labor. So again, just like that stripping of the membranes, that's amniotomy. So another name for it. When we talked about doing like the vaginal exam, another name for that would be, or actually, let me just give you this definition. So it's external cephalic version. So this is a procedure in which a fetus is rotated from breech to cephalic presentation by manipulation through the mother's abdomen. So as you're reading through this chapter, you'll see this mentioned that, if the fetus is presenting breech, sometimes they'll try to do this maneuver to try to get it to move so that they don't have to do a C-section. And usually it's not the nurse doing this, it would be the physician. So they actually do it through their abdomen, like with these different maneuvers that they do. And from what I understand, it does not feel good. So yeah, I just wanted you to know what some of those things meant. Okay. All right, so then we get to the operative vaginal delivery. So two of the things that is on here are the vacuum assisted delivery and the forceps. So we're going to talk about those for a minute. So with the vacuum assisted delivery, and I had this done with my daughter. So I got to a certain point, I was so dilated and I just was so exhausted from pushing all those many hours that nothing was happening. So they needed to do something, so they did this vacuum assisted delivery. So what they do is they put this vacuum cup on the fetal head, and suction is increased gradually until there's a seal there. Gentle traction is applied to deliver the fetal head. So basically the suction cup's put on the head and you are able to kind of pull out the head, and then once the head's out, you can kind of get the rest of the baby out a little easier. So nice things about this, like advantages, would be, easier application. Like it's no problem getting the suction cup on the head. Less anesthesia is required. So, think about this compared to a C-section. You would have to do all this anesthesia for a C-section. You would have less maternal soft tissue damage, and then fewer fetal injuries. So those are some advantages. So here's the guidelines for this. They say the fetal head has to be engaged. So that means it needs to be down in the canal like it's supposed to be. You have to have a max of 3 attempts for a period of a 3-pull rule. So that means if you do have this vacuum on, You can try like 3 times to use this to get the baby out, but after that you stop. If the cup pops off of the fetal head, this is a warning sign that you have too much pressure or an ineffective force is being exerted on the fetal head. The physician should proceed with a cesarean birth when the vacuum attempts are not successful. So that would be the next step if that was the case. All right, so what are some indications for using this vacuum assisted delivery? So if you have suspicion of immediate or potential fetal compromise, maybe you would want to do that. If you'd need to shorten the second stage of labor for maternal benefit, or if there's a prolonged second stage. So for me, it was just that prolonged second stage. Okay, so there's risks for the woman and risks for the baby associated with this. So for the woman, if you do this vacuum assisted delivery, sometimes you can get vaginal and cervical lacerations from this. It may cause you to extend the episiotomy. You could have hemorrhage related to uterine atony, bladder trauma, and also perineal wound infections. So those are some things that can happen as risks for the woman. For the baby, there's a couple of different things that can happen for the baby. So the first one is cephalohematoma. And so I think they have a good picture of this in the book. So from the suction cup on the head, as they're pulling, you'll get, like, after that suction cup comes off, the baby's head will be shaped funny afterwards. So that's the cephalohematoma. And what's a hematoma? It's just a collection of blood under the skin, right? And so this baby is going to be at increased risk for jaundice because of this. And after I read about this, I thought, wow, that's probably why my daughter had jaundice, because no one ever really explained that to us when, back then when we had her. But that's probably what happened. She probably had this cephalohematoma, and that caused her jaundice. Because remember, we got to go home. She was in the hospital for a normal period of time. We went home, and then we had to come right back to Children's and admit her to be under the lights because she was so jaundiced. Okay, other things for risk for the baby could be intracranial hemorrhage and also scalp lacerations from this vacuum. Okay, so that's the vacuum one. And then the forceps. In the book, it has pictures of what those forceps look like. They're kind of like tongs in a way, but they're metal. So this is an instrument that's used to assist with delivery of the fetal head, and it's typically done to improve the health of the woman or the fetus. So indications for this would be the fetal head is engaged and the cervix is dilated completely, but there's a suspicion of immediate or potential fetal compromise. So if you're thinking that the fetus is having trouble during birth and it's already engaged and the woman is dilated, and they just have this prolonged second stage of labor, maybe you're going to use this. They also, with this, they say other indications would be high level of regional anesthesia. Sometimes people have too much anesthesia and they just can't push effectively, so maybe that would be why you assist. And then maternal cardiac or pulmonary disease that contraindicates pushing efforts. So if someone had some type of cardiopulmonary problem where they couldn't push effectively because of that, then maybe this is why you're using the forceps. Okay, so again, there's risks for the woman and risks for the baby with the forceps. So for the woman, you're going to have pretty much similar to the vacuum stuff. So vaginal and cervical lacerations, you could have hemorrhage, perineal hematoma, extension of that episiotomy, bladder trauma, and perineal wound infection. So same things. For the baby, this is kind of scary to think about this, but yes, for the baby, it's going to be a little bit more than for the vacuum one. So yes, you can have a cephalohematoma with this too, but you can also have nerve injuries. You can have skin lacerations or bruising, skull fracture, or intracranial hemorrhage. So lots of kind of serious things. So you have to be super careful when you're using either one of these two things to assist with getting the baby out, because you could cause big problems. Okay, so this is talking about having a vaginal birth after a cesarean. So if this is your second baby and the first time you had a cesarean and you just want to try for a vaginal birth this time, sometimes it's doable, sometimes not. So what this is defined as is it's a labor and vaginal birth in a woman who has had a prior cesarean birth. So the benefits are a lot, you know. So you could have a shorter length of hospital stay. Your recovery period could be a lot shorter. You have fewer complications usually, um, fewer neonatal breathing problems. Like it's good if you could accomplish this. But the big risk of doing this would be rupture of the uterus. So because, you know, you're just not as strong there anymore after they cut you there, you know. When they cut you there to make your incision for the cesarean, that's just not the same anymore. That the skin and things around there just aren't the same. So, management. If you do take care of someone who is trying to do this, you're going to monitor that fetal heart rate. You are probably going to give medications to induce labor. Um, and then if you see any problems during labor, you're going to convert to the C-section right away. So you're going to watch this person really close to make sure they're doing all right. Okay, so this is where it starts to get a little interesting. There's all these crazy complications. Okay, so the first thing is post-term pregnancy and birth. Boy, would this be horrible. So this is a pregnancy that has reached or extended beyond 42 weeks gestation. Boy, I just remember at the end of my pregnancies, I was like, oh my gosh, get these babies out. I was so, at that point, you've had them in for so long and you're just so uncomfortable. I can't imagine going even another week like that. So, what this says in the book is post maturity, you know, you have both women and the infant that are increased risk for adverse things happening. So after 41 weeks, the neonatal and post-neonatal death risk increases significantly. There is an increased risk of stillbirth after 41 weeks as well. Also, with the mother, you're going to have an increased injury risk because the baby's going to be a lot bigger because it's been in there for so long. So you don't want to let people go too long. You know, you don't want to have like a 43-week baby or anything. That's just going to be not good. So you try to get this person's, you know, to have their baby a lot sooner. So probably you're going to schedule them for a C-section at some point if things haven't progressed. All right, and then the next thing is meconium stained fluid and birth. So as the fetus matures, vagal stimulation from the head or spinal cord will compress, and it may cause peristalsis and relaxation of the rectal sphincter, leading to meconium passage. So usually, if this happens and this meconium's in that fluid that the baby's in, you're worried that the baby will have gotten some of this into their lungs. And usually this is going to mean that they're going to have hypoxia. So this baby's going to be at risk for meconium aspiration syndrome. So after they're born, you're going to immediately suction out their nose, their mouth, and their pharynx, and they may need to be intubated if this is the case. So this is kind of a big deal. All right, multiple gestation birth. So again, this is just multiple babies. So this person would be at risk for preterm labor, labor dystocia, antepartum hemorrhage, stillbirth. And typically you're going to deliver them in the surgical suite because you're not sure how this birth is going to go. This birth can be pretty complicated. So if it's just twins, then you're definitely going to see if they can do it vaginally, but you'll do it in the operating room in case you need to convert to a C-section. Sometimes a person will be able to deliver one of them vaginally, but then the other one is not going to come out that way. Something is wrong, so then you might have to convert to a C-section for the other one. So it just varies on what could happen. So you always err on the side of caution, and that's why you do it in the surgical suite, which is what I did. Now, if this was someone that we're talking about that has triplets or even more babies inside, that's always going to be a C-section regardless. They're not going to let them try to do anything vaginally. So just have that in your mind. Okay, so stillbirth or intrauterine fetal demise. So this is fetal death after 20 weeks gestation. This would be horrible. And I don't know if you guys know anyone that's had this happen to them, but my mom actually had this happen to her. So we would have had another sibling at some point, but yeah, she had this happen. So what happens then is after they detect that the fetus has died and it's still inside the mother, you need to actually have them induced so that they can have this baby and get it out. So prolonged retention of a dead fetus puts the mother at increased risk for infection or bleeding problems. So she needs to get it out. So you would do an induction of labor within 24 to 48 hours after the diagnosis to deliver. And obviously this is a really emotional time, and it's hard for everyone involved. So you try to be as as sensitive to the mother and family as you can. You would wrap the baby up and let them hold it and do everything you can do to get them to have closure with what's going on. All right, and then the intra-amniotic infection. So this is inflammation of any combination of amniotic fluids, placenta, fetus, fetal membranes, or decidua. So with this, you can see a fever, tachycardia, increased uterine tenderness, purulent discharge from the cervix, and you would want to treat this with antibiotics. So with maternal obesity, pretty much in the United States, everyone's overweight anymore. It seems like the majority of people are. So especially with mothers having babies, if you have a mother that's overweight like that, she's going to be at risk for quite a few things. So you have to be really careful and watch her closely. So you can have shoulder dystocia that happens when they have their baby, so you're going to have to watch for that. Macrosomia means that they're going to have a bigger baby probably, so you're going to watch for that. They're going to be at increased risk of hemorrhage, delayed wound healing. They're going to be more at risk for DVT and infection. So you have to watch for all of those things. Okay, so with that shoulder dystocia, when you read about it in the book, this is just when you have a difficult delivery of the shoulders. So like you can get the head out, but then you're having a hard time with the shoulders, like they're stuck behind the bones or of some sort, like behind the symphysis pubis. So you have to do certain maneuvers sometimes to be able to get the baby to come out. So the book talks about two different maneuvers. There's a Mick Roberts maneuver. That would be probably the first thing that you do. And then there's a Woods corkscrew maneuver, which they're both kind of crazy. I can't even imagine trying to do that. But it would probably be the physician doing these things to try and get the baby positioned to get them out. All right, the other stuff This talks about prolapse of the umbilical cord. So what this means is the presenting part was not engaged in the pelvis, and so the cord starts to come out before the baby does. It lies below the presenting part of the fetus, and generally you're worried that there's going to be compression of the cord and things like that. So you would probably do a C-section for this if that was the case. Vasa previa. So this is when the fetal vessels, unsupported by the placenta or umbilical cord, traverse the membranes over the cervix. So pressure on unprotected vessels by the presenting part can lead to fetal asphyxiation and death. So usually this is found on an ultrasound. You can see this that way. And so you would plan for a cesarean birth if that was the case. All right, with a ruptured uterus, this sounds pretty significant, right? A ruptured uterus. So you're going to give oxygen to this person, you're going to give IV fluids, blood products, you're going to insert a Foley, because if the uterus ruptures, it's usually associated with a bladder rupture as well. So you're going to do that. So yeah, this is something that is a concern. So partial or complete tear in the uterine muscle, this is commonly associated with that VBAC, the vaginal birth after cesarean. So of course they would have to go to surgery to fix this. So yeah, you're going to have to really, just kind of treat the symptoms that you're seeing emergently, and then they'll fix it in surgery. Okay, so these last two things are pretty significant. So anaphylactic syndrome. So this is also known as amniotic fluid embolism. So it can be a fatal complication that can occur during pregnancy, labor, or birth, or the first 24 hours after birth. So this is an unpreventable and unpredictable thing that is happening. So you can't really prevent this. This is just something that happens. So the embolism forms from amniotic fluid, and I think they even say that inside the amniotic fluid you have things like the vernix and the I'm trying to think of the name of that, like that downy hair that babies have on them when they're first born. All of that kind of stuff is floating in the amniotic fluid, and so it ends up forming this embolism. And this triggers an anaphylactic reaction that triggers a cardiorespiratory collapse. So then, after this happens, then you could go into this next complication called disseminated intravascular coagulation. So we've talked about this before in our other class. So this is a syndrome that occurs when the body is breaking down blood clots faster than it can form a clot. So you basically use up all of your clotting factors, and it leads you to hemorrhage, and it can lead to maternal death. So unfortunately, this person could develop this anaphylactic syndrome, and then it could turn into this DIC, and then maybe this person dies as a result. So in the chapter, when you read about it, there's pretty significant percentages of people that die from this, because it's really hard to turn that around once they're in this. So definitely two really bad complications there. Okay, in the book, they talk about maternal trigger parameters, and there's like a red and a yellow that you're looking at, a red trigger and a yellow trigger. So this means that during any of these types of complications that we talked about in this chapter, these are things that you would do. So with a red trigger, that's going to be worse than the yellow, and the red means that you need immediate bedside evaluation. So you would not hesitate to call a physician to the bedside at that point. A yellow trigger means further clinical evaluation. So maybe you don't need someone right away, but you need to do something. Like something obviously is going wrong, and you need to do something further. So maybe you could just call at that point. Okay, so with red triggers, with the temperature, you would have a temperature of let me look at this for a second. Okay, so you would have a temperature less than 35 or greater than 38. A blood pressure of less than 90 or greater than 160. A heart rate of greater than 100. A respiratory rate less than 10 or greater than 30. And an O2 sat of less than 95%. Those are things that would be red triggers. For yellow triggers, the temperature would be between 35 and 36 degrees Celsius. Your top number, your systolic pressure, could be between 150 and 160, and your bottom number between 90 and 100. Your heart rate would be between 90 and 100, and your respiratory rate would be between 21 and 30. So those would be yellow triggers. Now this is on page 333 in your book. There's like some type of box about it that you could take a look at if you want to. Okay, so anyway, nurses are often the first members of the healthcare team to detect any kind of subtle signs or symptoms of developing complications. So their contribution to the rescue process is really crucial. This mentions people with pre-existing conditions and complications. That always makes it more complicated. At the minute a mother already has something else going on, like diabetes or hypertension or something, it's going to make the rest of the whole process more complicated. So you have to watch them very closely. You're supposed to assess high-risk situations continuously. And then with the ACLS algorithm, so I know you guys don't know ACLS yet, but eventually you may have to for your position that you end up having. So ACLS means Advanced Cardiac Life Support. So if you get to the point, like with one of those really bad complications that you have to initiate that, then with pregnant people, it's a little bit different. So the fetal monitor components should be removed before defibrillation. So like you don't want to leave on that fetal monitor because it can cause an arc to happen when you're defibrillating. So you would want to take those off of the mother. And then your hand placement for chest compressions is going to be different. It's going to be slightly higher due to cardiac displacement during pregnancy. And plus, you know, they have that big belly, so you're going to have to be a little higher anyway. And then early advanced airway should be considered as well. So maybe try to intubate them a little bit earlier on. So those are some of the things to think about with ACLS. And then anyone who is having really bad complications are usually going to be treated in an ICU unit. They're not going to be just on the regular OB floor. Okay, so when unsuspected crises occur on the OB unit, nurses and other clinicians must act quickly to take the appropriate steps to ensure best health outcomes. So that's that chapter. Okay, and then this is the last one here. So we've got chapter 14. So this is high-risk postpartum nursing care. Okay, so the focus on postpartum nursing care is to reduce the woman's risk for complications related to childbirth and identify complications for early prompt intervention. some common things that you might see, common problems postpartum, would be hemorrhage, infection, severe hypertension, and also venous thromboembolism. So with postpartum hemorrhage, so there's about 5% of postpartum women experience this. So it can be a big deal, and you're going to have increased morbidity and mortality as a result of this. So just as you can imagine, when someone's losing a ton of blood, they're going to go into hypovolemic shock. And so some of the things that you would see would be you're going to have a low blood pressure. You're going to have a high heart rate. You're going to be really anxious. You're probably going to be breathing fast. Some of those types of things. So think about some of those signs and symptoms and kind of what you would do to treat shock in just a regular person. And you're going to do the same thing here. Now, in here, it talks about quantification of blood loss. So how are you going to decide how much blood loss this person is having? So a normal blood loss from a vaginal birth would be about 500 milliliters in 24 hours. So you're supposed to weigh blood-soaked items and drapes to estimate the amount of blood loss. That's kind of how you figure this out. And then there's also threshold parameters with this result, with postpartum hemorrhage. So again, we have red and yellow parameters that we will indicate like how much of a problem something is. So with the red parameters with this postpartum hemorrhage, your temperature, you're going to report if it's less than 35 or greater than 38. With your systolic blood pressure, you're going to report if it's less than 90 or greater than 160. Your diastolic pressure, you're going to report if it's greater than 100. With the heart rate, you want to report if it's less than 40 or greater than 120. And with the respirations, if it's less than 10 or greater than 30. And with the O2 sat, if it's less than 95%. That's red parameters. So things that would cause you to get someone to the bedside right away. Yellow parameters. With the temp, it's going to be 35 to 36. The systolic pressure is going to be 150 to 160 or 90 to 100. And the diastolic would be 90 to 100. The heart rate you would call if it's 100 to 120 or 40 to 50 even. And then your respiratory rate, it would be 21 to 30. So those would be yellow parameters. Okay, so some causes for postpartum hemorrhage. There is something that they do like these T's, so the tone, tissue, trauma, thrombin disorders. So there's a table about this in your chapter. It's on page 420, table 14-1. So the tone is talking about uterine atony. So remember we said if you have uterine atony, usually that's going to cause you to bleed more. So we talked about massaging the uterus, right? With tissue, this would be retained placental fragments. With trauma, this would be because maybe you have a lot of lower genital tract lacerations. Maybe that's causing the bleeding. And then with thrombin disorders, this is where that DIC comes into play. So if you've used up all of your clotting factors, now you just can't get this person to quit bleeding. And that could be the case. Okay, so there's different staging to this hemorrhage issue with postpartum hemorrhage. So they have stages 1 through 4. So I'm going to kind of talk about those for a second. So stage 1, this is where maybe you have more than 500 milliliters of blood loss vaginally, or you have more than 1,000 milliliters of blood loss from a C-section. You always want to make sure that this person has a large gauge IV, so like 16 or 18 gauge, because you're going to be giving them a lot of fluids and blood products, so that's going to tolerate that better if you have a bigger gauge. You're probably going to give them a lot of IV fluids during this time. You're going to insert a urinary catheter. You're going to be doing fundal massage. And then sometimes they'll have you give oxytocin or misoprostol. And there's others too, but maybe you'll be giving some of those medications. You want to have 2 units of packed red blood cells typed and crossed and ready to go. And then you want to try to determine the etiology and treat that. So you want to figure out what's causing this bleeding. And then prepare an OR if indicated. So that's stage 1. Stage 2. So now you've done all of this stuff in stage 1, but now stage 2 is happening. So you're having continued bleeding, and maybe you have more than 1,500 milliliters of blood loss. And now you've done 2 uterotonics with normal vital signs and lab values. Uterotonics are types of medications that you would give to help get this under control. So uterotonics are like oxytocin, methergine, carbaprost, and misoprostol. Those are examples of uterotonics. So now that you're in stage 2, you're going to mobilize additional help. So you're going to call people and get more people to the bedside. You're going to place a second IV site. You're going to draw stat labs, maybe prepare the OR. You're going to continue those stage 1 meds that you did. Now you're going to obtain that blood that you had typed and crossed, and you're going to give it. So you're going to give 2 units of blood, and then you're also going to thaw and have ready 2 units of fresh frozen plasma. You're going to escalate the therapy with the goal of hemostasis and huddle and move to stage 3 if continued blood loss and abnormal vital signs. So once you get to stage 3, now we have all of this continued bleeding. You have more than 1,500 milliliters of blood loss. You've already given 2 units of blood. The patient's still at risk for occult bleeding and coagulopathy. They have abnormal vital signs in labs, and now you're also seeing oliguria going along with this in stage 3. And remember, do you guys remember what oliguria means? Anyone have a thought? Oliguria just means that you have decreased urine output. And so, like, if you were looking at a 24-hour period, you know how we should have at least 30 milliliters an hour of urine output every hour. So if you had, like, say, 400 or less, that would be like an oliguria for a 24-hour period. Okay, so in stage 3, we're going to mobilize more help. We're going to probably move this person to the operating room. And we're going to announce clinical status. This means we're talking out loud to everyone in the room. We're saying, okay, what have we done so far? This is what our vitals are. This is how much blood that was lost. What have we come up with? What do you think is causing this blood loss? So we're trying to talk with each other and trying to figure out what's the cause. We're going to outline and communicate our plan and continue our stage 1 meds, and then initiate massive transfusion protocol. So if they need to get more blood products, they're going to get them. Stage 4 is pretty bad. So now we just have this hemorrhage with cardiovascular collapse. So remember those complications we just talked about a few minutes ago, those are probably going to be what's going on here. So we have profound shock or amniotic fluid embolism. We're going to do our ACLS protocol now. And then we're going to do aggressive massive transfusion and an immediate surgical intervention. So they're going to take them into surgery, open them up, and try to figure out what's going on to get them to quit bleeding. And then they also mentioned hysterectomy here. So if there's just like a massive bleed going on, they may just go ahead and do a hysterectomy to get it stopped. So scary situation, right? All right, so with these coagulation disorders, that DIC is the worst. Again, it's a complication of an underlying pathological process. So usually something else will kick them off into this. The DIC is not like a thing itself, it's a result of something else happening. So in DIC, your coagulation pathways are hyperstimulated and the woman's body breaks down blood clots faster than it can form them, and it quickly leads to depleting clotting factors and then eventually death. The anaphylactoid syndrome is where your amniotic fluid that contains fetal cells, lanugo, and vernix enters the maternal vascular system, and this initiates a cascading process that leads to cardiorespiratory collapse and then eventually DIC. And then with VTE, this is just a blood clot that starts in your vein and then it breaks free and it can travel to other places like your lungs and cause bigger problems like a PE. So as you can see, a variety of complications can occur in the postpartum period related to alterations in clotting mechanisms. So there's quite a few things that can happen. So which of the following is the treatment of choice for primary postpartum hemorrhage? So we're probably going to say oxytocin here, so B. Okay, so then this gets into a little bit like about infection and stuff like that. So endometriosis, this is another common problem. So this is infection of the endometrium and myometrium and or parametrial tissue that usually starts at the placental site and then it spreads to encompass the entire endometrium. So risk factors for this would be someone who had a cesarean birth, a prolonged rupture of membranes, internal fetal and uterine monitoring, multiple cervical exams during labor, and then obesity would be another risk factor. So with assessment of this, you would see things like an increased temperature, uterine tenderness, tachycardia, malaise, headache, chills. And then that lochia that they have, it's going to be heavy and foul smelling. So how they treat this is usually with broad spectrum antibiotics through the IV and also a lot of rest. And then so our nursing actions would be to instruct women to change her peri-pad every 3 to 4 hours. We want to encourage intake of fluids so they get really good and hydrated. And then we also want to educate on a diet high in protein and vitamin C to help with tissue healing. Okay, and then wound infections. So this could be, at the episiotomy site, at your cesarean incision site, anything like that. So risk factors for wound infections. Again, obesity is always right there. So that's a big issue. Diabetes, because you have a hard time healing up things with diabetes. Malnutrition, long labor, premature rupture of membranes, corticosteroid therapy. All of those things put you more at risk for a wound infection. So again, things that you would see, this will be the same as any other type of incision that we talk about in any other class. So you're going to see redness, you're going to see heat, swelling, tenderness, purulent drainage, maybe a little bit of a fever, increased pain at the incision site. All of those things would indicate infection. So typically what they do for this is they need to open up the wound and drain it, and then they're going to put them on antibiotics. So a lot of times they actually have to pack the wound and let it heal from the inside out. So with nursing actions, we want to assess the perineum or the surgical incision frequently. We're looking for redness, edema, ecchymosis, discharge, how approximated it is, all of those things. And then we talked about mastitis before in one of the other chapters. So anyway, again, this is like an infection of your breast. So anyone who's at risk for this would be someone who's had it before, so a history of mastitis with a previous infant. If they have cracked and or sore nipples, if they typically use only one position for breastfeeding, ample milk supply and reduction in the number of feedings would be another thing. So maybe they're not feeding them enough and then they have this overproduction there. So things that you would see would be breast tenderness or warmth to the touch, breast swelling or hardness, skin redness, and also fever. So if this gets so bad, then usually someone needs to come in and get looked at, and they'll put them on oral antibiotics for 10 to 14 days. Things that we can do or tell the patient to help them with this would be apply warm compresses to the affected area for comfort and promote circulation. You want to tell them to empty both breasts fully during breastfeeding. Air dry the nipples after breastfeeding, sometimes that helps. And then also continue to breastfeed or pump regularly. So even if they're having problems, they still need to get that milk out. Okay, so then this gets into a little bit about diabetes. So of course we want really good glycemic control and follow-up after delivery, because sometimes someone will be gestational diabetic and then they'll turn into a type 2 diabetic pretty quickly afterwards. So I know for me, I was gestational diabetic, so after I had the babies, they didn't really check my blood sugar or do anything at the hospital, which I was kind of concerned about. I thought they should have. So I said something to my physician after pretty shortly after I had them, and then she made sure she checked me really good. And so now every time I go, she checks me all the time. So it's a continued ongoing thing. So with diabetes, you want to do a postpartum screening at 6 to 12 weeks. This is recommended for all women who had gestational diabetes to identify if they've gone into, full type 2 diabetes. You want to counsel women with a history of gestational diabetes that they have a 7-fold increased risk for developing type 2 diabetes. So that's a lot, right? Women should also be informed that they are at high risk for developing gestational diabetes with subsequent pregnancies. So if they get pregnant again, they're probably going to have it again. And then you want to tell them to exercise and increase their activity, because this is going to help, kind of ward that off for a while. All right, and then this gets into severe hypertension. So women in the postpartum period with an acute onset severe systolic hypertension, this means their top number would be greater than 60 or about at 60, or a diastolic hypertension, which would be their bottom numbers greater than 100, they need urgent antihypertensive therapy. So you want their range to be like the top number between 140, 150, bottom number between 90 and 100, somewhere in there. So maternal stabilization should occur before delivery, even in urgent circumstances. So you always want to stabilize that mom's blood pressure before you would deliver the baby, because you don't want that to go out of control. So typically what they do, first line management, would be labetalol and hydralazine. Those are the kind of things they reach for first. Also, the book goes into a little bit of detail about how some of those medications can cause problems. So if you give parenteral hydralazine, meaning like say you give it through the IV, that mom is going to be at increased risk for maternal hypotension. So it can cause you to like go down super low. Nifedipine has also been associated with increased heart rate and overshoot hypotension. So you like drop them too much. So you have to really watch closely with whatever you put them on. Okay, and then this also talks about postpartum depression and psychosis. So anyone who's at risk for this would be someone who's had a history of depression before, poor quality relationships with their partner, if they're single, or if they're low socioeconomic status, anyone like that would be more at risk. So with assessment, some of the things that you would see if someone had this. So they could have sleep or appetite issues. They could be super fatigued, like more than expected for caring for a newborn. They could have anxiety, inability to care for themselves or their baby, like they just can't seem to get it together, those types of things. So you want to watch someone with depression pretty closely, because if this develops into like a major depressive disorder, that's going to be an issue here. So major depressive disorder is when a woman has a depressed mood and a loss of interest or pleasure in daily activities for at least 2 weeks, in addition to 4 of the following symptoms. So there's like a huge list. So things like weight loss or weight gain, insomnia or hypersomnia, decreased energy or fatigue, feelings of worthlessness or guilt, decreased ability to concentrate, and then there's even more. So it's a big deal. So you want to make sure you get them the right help. So there's like mild depression, moderate depression, severe depression. So you have to know kind of where they fall at. So with mild depression, they say, oh, we'll just do some therapy, they should be good. Moderate depression, they'll put you on antidepressants and do some therapy. And then severe or suicidal type people, they need a lot more help. So they need intense psych care, crisis intervention, antidepressants, therapy. And then sometimes they get to the point where they even need that ECT therapy. So it just depends on where you're at with all of this. But for us as nurses, we need to monitor our mothers and infant interactions. Just look at them really closely to make sure that they're bonding and not having trouble. Okay, acute hypertension is treated with what? This is going to be D, all of the above. Okay, so the most common cause of severe maternal morbidity and mortality postpartum, some of the most common causes are preventable. So most complications occur after discharge, yet only 60% of women receive follow-up care. So follow-up is super important. We need to really make sure we push that on people to understand how important it is to come back and get looked at. Nurses have a key role in prevention, early identification, and follow-up postpartum. Okay, so that's that stuff. Let's see if I can find my other thing here. wish you guys had access to this. This would make it so much easier. Okay, so with our book is like a F.A. Davis book. And so they have something called Davis Edge that's associated with this. And so it's just like practice questions basically. So if you guys had access, you could get into here and do this whenever you wanted. But so anyway, I made this one this morning real quick. I didn't look at these questions super close, so some of them might not be perfect questions, but that's okay. So this here, let's see if we can look at these questions. Let's see if I can do this right. Let me see if I can do it this way. Yeah, if this will only cooperate here. All right, let's go in this way. Trying to figure out how we can get in here and do it. Now that I made it, it's like, how do I get in? Um, well, hold on. Let me just. Here, we can just do it this way. I can't figure this out. So let's do it this way. Oh, wait a minute. All right, we'll just get in and see if we can do some of their questions together just to have some practice with it at least. Let's see. All right, so let's just look at these questions together. Let's see, details. Here we go. Okay, a postpartum nurse caring for a patient 3 days post-delivery notes brown vaginal discharge. How should the nurse document this finding in the electronic health record? So would you say lochia rubra, lochia serosa, lochia alba, brown vaginal discharge?
D or 4.
So they're saying lochia serosa is the correct answer. So down here under rationales, see where it says the rubra is going to be red and bloody, the serosa is pink or brown in color, and the alba is clear or whitish. Okay, a postpartum patient asked the nurse if she needs to use contraception while breastfeeding. What's the most therapeutic response by the nurse? Yes, because breastfeeding is not an effective contraceptive method. You cannot get pregnant as long as you are breastfeeding. It takes 9 to 10 weeks for your hormone levels to allow you to get pregnant. That is a question for your doctor to answer. What would you say?
1.
Yeah, I know this shows you. I just want to make sure you are kind of looking at some of the topics here. So yeah, you can't rely on that to be your contraceptive method because you're going to end up getting pregnant again really quickly if that's the case. All right, look at this one. So a postpartum patient who had an emergency cesarean delivery due to abruptio placenta is oozing blood from her incision and IV site and is becoming increasingly anxious. Which complication does the nurse suspect based on these assessment findings? So do you suspect hemolysis, elevated liver low platelet syndrome, that HELP syndrome? Do you suspect DIC, pulmonary edema, or wound dehiscence?
Do.
DIC.
Yeah. So when you're looking at your options here, this HELP syndrome, it's all going to be about your platelets and your liver, right? So in the question, it doesn't say anything about either one of those. So you know it's not that. And then the clue in here that it is DIC, I don't know if you remember us talking about that back in that other class we did together, but we said that you can ooze blood from pretty much any orifice when you have this. So it's really scary. So in the question, it's saying that they're oozing blood from their IV site as well as their incision. So more than one place, you know? So pulmonary edema, it doesn't say that they're having like a hard time breathing or anything. And then wound dehiscence, it's not saying anything about that. Okay, a mother who has been breastfeeding for 3 months calls the clinic to speak to the nurse. She reports a fever, unilateral breast swelling, and pain and redness. She's worried about continuing to breastfeed. What's your appropriate response? So would you say pump and discard your breast milk until you finish your course of prescribed antibiotics? Would you massage the area while you breastfeed to treat the infection? Your milk is not infected, so you can continue to breastfeed and we will prescribe an antibiotic. You will need to be more diligent about cleaning your pump supplies.
Three.
Yeah, so this is that mastitis, and we've talked about it before. So this is something that is a common thing that happens, and it's very painful. So this woman in the question has a valid concern. If they're going to be put on an antibiotic, what should she do? Should she not, give her baby the breast milk because she doesn't want to hurt her baby? So I mean, it is a valid concern. So yeah, she still is able to breastfeed. She doesn't want to not like get her milk out. That's important to still pump and do things. And it's not a matter of her like not cleaning her pump good enough or anything like that. It's nothing like that. See down here under options, look at this. Mastitis is typically caused by Staph aureus and is spread from the baby's mouth or throat. So that's kind of how you would get that. Okay, the nurse is caring for a patient newly diagnosed with endometriitis. What assessment findings are consistent with this? So would you see abdominal cramping and cloudy urine, dizziness and hypotension, edema and hypertension, uterine tenderness and foul-smelling lochia?
4.
Yeah, so it's not like a problem with your blood pressure. It's not that you're well, I mean, you're bleeding, but you're not hemorrhaging per se, so you're not going to have like a low blood pressure. Doesn't have anything to do with your urine, so you know it's not that first one. So it has to do with your uterus because it's the endometrium. That's kind of what our problem is here. So the uterine tenderness and foul-smelling lochia. Man, this program is crazy. I just want to look at the one I made, darn it. Oh, maybe this is someone else's. There we go. Okay, so this says the nurse is caring for a patient who delivered via C-section 2 hours ago and is now in the recovery room. Upon reviewing the delivery record, the nurse notices that her estimated blood loss was 800 milliliters. What's an appropriate nursing intervention?
Number 2.
That's what I'm thinking. Oh, is it not going to let me answer? Here we go. What's this saying? Oh, okay. They're saying this is normal because it's a C-section. If you're with vaginal delivery, it's like 500 milliliters, but with C-section, you can have up to 1,000 milliliter blood loss. So this would be normal. So this would be 1. But yeah, you're right though. If it was like, you know, if we were just talking about a regular vaginal birth, then yes, this would be considered like a stage 1 hemorrhage, and then you would have to treat it, and that's probably what you would do next. Okay, a mother who has been breastfeeding her for 3 months calls the clinic to speak to the nurse. We just did this one. Yeah, we did that. Hold on. Okay, how about this one? The recovery room nurse is completing a postpartum assessment on a newly delivered patient. Upon assessment, the nurse finds the peri-pad saturated with lochia with large visible clots. What's the priority nursing intervention based on these findings? What do you think?
Massage the uterus.
Yeah,
Yeah.
number 2.
I would say. Let's see. Yep. Good job. Let's see. We just did that one. How about this one? The nurse is assessing a patient who is G5, T5, P0, A0, L5, and delivered vaginally 4 hours ago. Patient's labor history includes a 16-hour oxytocin induction for a macrosomic infant, meaning that it's a big baby. Assessment findings include a boggy uterus and completely saturated peripad with the presence of blood clots. What does the nurse identify as the most likely cause for the increased bleeding?
Either tone or trauma.
So they're saying tone. So uterine atony and decreased tone is most likely the cause of their stuff. But yeah, I mean, I could see either one, honestly, because it was a big baby. So yeah, you could have trauma. Let's see. All right, so the oncoming nurse is reviewing her assignment for the day and would like to identify who to see first based on acuity. Which woman is at greatest risk for primary postpartum hemorrhage?
Three.
It's the one, because she's obese. Remember we said obesity was like a big
Yeah.
risk factor? And
Plus
then-
the induced labor.
Yeah. So that it would be that one. The nurse is caring for a patient who was diagnosed with gestational diabetes at 28 weeks of pregnancy. The patient had an uncomplicated vaginal birth 12 hours ago. Which statement made by the patient would require further education?
Three.
Or two. Yeah.
So we already know that you do have a higher risk of developing type 2 diabetes once you have gestational. So you know that's a correct statement. So they don't need further education for that, right? And then I need to see a provider preconception glucose control prior to my next pregnancy. Yeah, because every subsequent pregnancy you have, you can have gestational diabetes. So that might be true. Breastfeeding my baby will help reduce my risk for developing type 2 diabetes. Yes, believe it or not, they do prefer you to do that because it does help with that. So the thing that you would choose would be 2. Because they say, so there's no need for follow-up. That's not true. You should be following up. Let's see. Postpartum mother delivered 2 hours ago and has a history of recurrent UTIs. She's very anxious about the risk of UTI after delivery and asked the nurse what she can do to decrease her risk. Which response by the nurse would require further education regarding recommendations to prevent UTI? I don't know, this one's kind of weird. So obviously, you don't want the mother keeping track of how much she's putting out. That's kind of stupid. I will need you to keep track of your urine output. I mean, why would you do that? So definitely not that one.
Would it be 1?
It's going to be 4. So you will need to keep track of your oral intake with the goal of drinking at least 1,500 milliliters a day. So the idea is if she increases her drinking, that maybe that will help prevent it. I don't know. I wouldn't have someone keep track of that. That's kind of stupid. Okay, so this says the nurse is caring for a patient on the postpartum unit who has been diagnosed with subinvolution post-delivery. The nurse understands that subinvolution is associated with what labor and birth complication? Any guess? So this would be 4 and 5. This doesn't even say select all that apply, but it was. So retain placental tissue and infection and also presence of uterine fibroids. So that's kind of what they're talking about there. All right, here we'll just do a couple more and then we'll say we're done. All right, we did something like that already. Okay, how about this? The nurse is planning care for several postpartum patients. Which nursing actions should be included in the care plan to reduce the risk of postpartum complications? Select all that apply.
3 and 5.
Distension of the bladder, 6%. One, 3, and 5. So we forgot 1. Yeah, so if you're looking at their records, you know, if you look at their history and that kind of thing, that can point you to a potential problem, you know. So that would be included too. Okay, the nurse is assessing a patient who suspects postpartum hemorrhage. Which method of measuring blood loss should the nurse include? So let's see what they say here. So
2 for 3.
they're saying 3. So use under buttock calibrated drapes. So I guess the way these drapes are, you can measure the blood loss because of the way that the drapes are, because they're calibrated or something. I don't know. I'm not sure what that means. So like 2, weigh soaked pads and add the weight of dry pads. That last part makes that wrong. And then examining all pads and linens for saturation. Yeah, we would do that, but I mean, how is that going to quantify how much? It's not, right? So I don't know. I'm not sure quite what this means, but I'm assuming the drape that's underneath them has a way of like collecting the amount of blood or something, so you can get like a physical measurement. Does anyone have a thought about that? I don't know if I'm correct or not in saying that, but okay, so real quick before we get off here, I'm going to take a look at your actual OB test that you're going to have next week. I'm just going to see if there's anything in particular I want to say about it. So everyone got my tips to know, right?
Yeah.
Yeah.
Okay. So on this test, you know, she's got quite a few selectols. There's a lot. So you know that question that we just did on that Davis Edge about subinvolution? Do you guys understand what that is?
Not fully.
It's like where the uterus like doesn't return to like the correct size, like it's doesn't contract or whatever.
Yes. So because it doesn't do that, there's a reason for that. And like on the test, there's a question about it, and it's like, what is the most common cause for subinvolution of the uterus? And it's usually because you have retained stuff in it, like placental fragments or infections in there, or something like that is going on to cause it to not go back to the right spot. Okay, so make sure you review that. And then like some of these selectols, they have stuff like, you know, there's stuff about the biophysical profile, what assessments are included in that, you know, so there's like a list of things. So just make sure you're looking through some of that pretty good, because there's a lot. There's a selectol about jaundice. There's one that has to do with behavior and physiologic cues that indicate pain in a baby. Like what would be some things that you might see? What would you guys say to that? And like what, so if you're trying to assess if a baby was having pain, what would you see? What do you think? Remember we said it's kind of hard to assess. So they have like these scales and stuff that you can go through, and it looks at all of these different things. So regardless, if you're thinking this baby is in pain, or you're worried that they might be in pain, what can you do to help with the pain? What would be something you could do? No thoughts?
Like comfort breastfeeding or like swaddling maybe.
Swaddling is one of them, yes. So if you're thinking a baby's in pain, if you swaddle them, that usually kind of helps calm them down. It makes them feel better. The whole idea of like the sucking process, you know how like sometimes people will use like a pacifier or whatever to stick in their mouth. Non-nutritive sucking, that's like something that will help calm them. If someone, like think about like after babies first come out, you know, when they first come out, when they're born, they're all flipping out and crying and cold because of all of this stress of just coming out into this environment where they're cold and all of this stuff. So skin to skin contact would be another thing, right? So that's going to be something that calms them. and like gets like everything more under control. And then also, I don't know if you've ever heard this, and I think it might be in with the stuff about circumcision. They were talking about how, like, if a baby has to undergo a procedure like that, sometimes they will give them a pacifier that's dipped in sucrose. That's like dipped in, some type of sugar or whatever. And sometimes that will help calm them down. So those are the types of things that you would think about when you're talking pain in an infant, things that you could do to help make them feel better. Those would be things you could do. And then I don't know if you guys remember, we talked about in class one time about signs and symptoms that a baby is hungry, like hunger cues. There's a question about that, like a whole big select all that has a ton of responses for that. So when you're looking through your reading specifically for some of these things, just like really look at it well, because there's a lot of select alls. I don't know if you guys have looked at that stuff yet. Did you have any specific questions that you're having a hard time finding or anything? You may have just looked at your community so far. I don't know if you looked at this one yet.
Yeah, I've mostly just been studying for the community, going through that study guide.
Okay,
For me.
that's okay. So, yeah, concentrate on that today. And then once you start looking at this, if you start having questions, just ask me and I can try and direct you into the right spot to look for it. Okay?
Would it be possible at all, maybe we could have like a study session or something like that on like Monday or Tuesday for before our OB exam too? I don't know, just to like we could go over questions that we are understanding or something like that just before the exam maybe.
Possibly Monday. It would probably have to be, I'm trying to think when my exam is for my other class. Here, let me look at my email for a second. It's in there. Should just post it, I swear. Let's see, my other exam. Oh yeah, we could do it in the morning on Monday. So I have an exam that starts at 12:30 on Monday. So we could do it sometime in, before then. Like, I don't know, like, do you want to say 10 or something? Would that work?
Yeah.
Okay, I can do that. Let's just say
Yeah.
10 o'clock then. And then we'll just touch base with each other and make sure you feel pretty good about this next exam. So just remember, I won't be the one giving you the exam on that Wednesday because they're making me do this stupid BLS stuff. So I have to do that on Wednesday, so I won't be around. But you will have someone that will be here, and I'll let you guys know who it is maybe on Monday when we meet, because I have to check back with her and see who she found. Okay?
Thanks, Mrs. Silk.
All right, no
Thank you.
problem. All right, so remember, do not forget to do your OB proctor remediation today. Get it done, turn it in, so you can all get some points, okay? So go study for your community, and let's all do really good on that, and I'll see you at 12:30, okay?
Sounds good. Thank you.
All right, see you later.